knows Dr. Dan Sorescu, one of our Emory's Midtown-based cardiologists specializing in heart failure. If you'll remember, he spoke recently on systolic dysfunction, and so this is sort of a paired lecture on heart failure, and he'll be focusing on diastolic dysfunction today. So,
thank you, Anna. We have excellent proven outcomes for patients with heart failure with low ejection fraction. In contrast with that, when it comes to evidence-based medicine for proven outcomes for heart failure with preserved systolic function, medicines to improve survival, we really have nothing. Medicines to reduce hospitalization, maybe ARBs, very little evidence, but not all of them show the same thing. So really, when it comes to that, I think the best way to summarize it will be to quote Pink Panther, "Let me bring you up to speed. We know nothing. You are now up to speed." So I thought that would be a good way to introduce what we really know about heart failure with preserved systolic function in terms of evidence-based medicine. That does not mean that we have not made any progress in this field. So really the next 55 minutes, actually, I would like to take advantage and try to give you a perspective through a modern cardiologist and I would say a well-rounded clinician. What is it that actually we can do to help these patients, both in diagnosis, prognosis, and treatment for these patients? So, so I will talk about definition, epidemiology, and diagnosis, and the purpose is to try to summarize things that everybody agrees, not things that people disagree on. Second, I'm going to talk about how a cardiologist is seeing echo for diastolic dysfunction. Many times we use terminology that for the eyes of an internist, like pseudo-normalization on the echo, restrictive physiology. What does it mean? Really, what, and I think I cannot really go through all those stages of echocardiographic progression without also going through pathophysiology. And last but not least, I will review the evidence-based medicine for the treatment of heart failure with preserved systolic function, but also give you hopefully a hands-on practical approach to how we can help these patients. So let me talk a little bit about definition, epidemiology, and diagnosis. And I would like to define and clarify some nomenclature, particularly for the house staff and for students, which I'm sure they're always confused about how clinicians use interchangeable all kinds of terms that sometimes are very different. So what do we mean by heart failure with preserved systolic function? I will tell you what government means, and I'll tell you what experts mean, and I'll tell you what it means on day-to-day practice, because unfortunately, sometimes those three concepts are a little bit different. So number one, what government and Medicare wants when we bill for a patient in the hospital, anybody who comes with acutely decompensated heart failure, with signs and symptoms of heart failure, with an ejection fraction, it's over 40% on any kind of way you can diagnose that, whether it's echo, whether it's ventriculogram, whether it's PET. That's what Medicare would like us to call heart failure with preserved systolic function. Unfortunately, that by itself may be a misnomer, because while the heart failure can be with preserved systolic function, that could be a patient who has end-stage renal disease, is 20 years old, shut down their kidneys, their volume overloaded. If we don't dialyze them, they're going to go and die because of congestive heart failure and heart failure with preserved systolic function. But that doesn't mean that if I treat that heart, which otherwise is normal, is going to save this patient. I need to treat something else. So in a way, it's a misnomer because it doesn't really tell you what causes this patient to have heart. It's what I would call non-cardiac heart failure, all right? And yet we're forced to call it the same way, heart failure with preserved systolic function. However, most of the experts will agree that in the absence of a better term, we really use this as a clinical syndrome. Anybody who comes with acute decompensated heart failure with a relative preserved ejection fraction. But the take-home message that I would like for you to take is that don't give up. Try to identify an underlying structural heart disease that can be associated with that and focus on that. So, for example, sometimes that underlying structural heart disease is heart itself, like hypertrophic cardiomyopathy. LVH, 3 centimeters, that's obvious, the reason for the heart failure with preserved systolic function. But sometimes could be a patient who has a little LVH and has severe sleep apnea with right side heart failure and he's got volume overload. Sometimes can be a patient who's got a creatinine that's 4. Even if he has LVH, we're going to call it heart failure with end-diastolic dysfunction. But unless you focus on getting the kidney better or normalize the volume status, you're not going to help the patient. So that's what I would like for you to understand. The second think is, so from that perspective, we can separate heart failure with preserved systolic function, what I call cardiac heart failure, which will be diastolic heart failure. That's what cardiologists like to call. Or I would say even non-cardiac heart failure with preserved systolic function. And maybe that'll help us to consider, the problem. Sure, there is an underlying structural heart disease there. The heart is a little stiff, but somebody can live with that heart for 50 years and not suffer necessarily from that. Maybe there's a non-cardiac cause that has, triggered now what's happening. And then diastolic dysfunction per se, it's a terminology that we derive from pure on echo data. So you can have what we call abnormal impaired relaxation pattern, and that by itself does not mean patients in heart failure. To call it heart failure, you have to have signs and symptoms of heart failure. So you need signs and symptoms of heart failure. You need an EF of about 40%, and you need one way or another to demonstrate some kind of diastolic abnormality on the echo or anything else. And what really American Heart Association would like to and insist that we should try to make an effort, we should not have some other reason to explain that heart failure that is a clear identified structural heart disease, like valvular disease, pericardial disease, or systemic illness which causes that. So, so when we go to that, American Heart Association, American College of Cardiology, says that we often incorrect diagnose the patient with heart failure. In other words, they want us, if the patient comes with heart failure with preserved systolic function, has got a little LVH, but what really patient has is sleep apnea with 40 pounds fluid overload. That's right side heart failure. You shouldn't call it heart failure with preserved systolic function. Now, for Medicare and billing purposes, we're going to call it that, but I also make my house staff also write, well, due to right side heart failure, due to severe pulmonary hypertension, due to untreated or poorly treated sleep apnea, and that's or related or aggravated by whichever you want to say. Why? Because one way or another, you have to point to what is it really that you can actually causes this, they can try to interfere with him on long term to help the patient. Make sure we don't have primary valvular disease. Often, restrictive infiltrative cardiomyopathy like amyloid sarcoid can be, the IHA wants us to recognize that as a separate entity, pericardial constriction, reversible systolic dysfunction, severe hypertension, myocardial ischemia, heart failure associated with high metabolic demands. These are all diagnoses that should be separated from the heart failure with preserved systolic function. Cor pulmonale, chronic pulmonary disease with right side heart failure, pulmonary hypertension associated with pulmonary vascular disorder, atrial myxoma, obesity, or sleep apnea. I added that myself because I actually think that probably about half of the patients come in the hospital at Crawford Long with heart failure with preserved systolic function. One way or another, they have right side heart failure related to sleep apnea or obesity or metabolic syndrome. So now how about some epidemiology of heart failure with preserved systolic function? We started to study this in the last 20 years, and as opposed to epidemiology of systolic heart failure, there's actually quite a big diversity. But what seemed to be the common agreement is about, overall, it's about 54, about a little bit over half of all patients cases with heart failure. It is projected right now there are about 5 million patients living with heart failure in this country. Probably in about 5 years, there will be 7 million. Everybody agrees that probably 2/3 of this will be heart failure with preserved systolic function. And the reason why is because factors that are associated with heart failure with preserved systolic function, age over 75, female sex, history of hypertension, atrial fibrillation, whether it's paroxysmal or not, and higher BMI and obesity. So if I were to look who makes the big mass of heart failure with preserved systolic function according to the definition, there are ladies who are over age 70, little old ladies with small stiff hearts and arteries. And actually, if you get to live up to age 90 in this country, the woman to men ratio is 8:1. So who's going to be that? It's pretty obvious. And if this population were living to get older, live longer, obvious the contribution of the patient with of these patients to heart failure is going to increase with time. It's very interesting, actually, these patients who you have identified this way with heart failure with preserved systolic function, you could not find any other etiology for heart failure. They are less likely to have coronary disease or even risk factors for coronary disease. And I think what you do is you select a certain group, and then it's, according to this, it appears that we're dealing mostly with age-related heart failure, basically. All right. However, if the same patient is not 75, will have a female sex, his hypertension and paroxysmal AFib and higher BMI, and it's age 30, then we'll call that hypertensive cardiomyopathy. And but from this definition standpoint, we're still going to call it heart failure with preserved systolic function. I would actually make a case that those are completely two different human beings and completely different underlying structural heart disease and pathophysiology. One is caused by hypertension at age 20, which by the time the patient reaches to be age 60 has already had the usual complication, heart failure, MIs, end-stage renal disease, on dialysis, while the other patient who lived to be at age 75 did not get any other disease, has got age-related cardiac dysfunction, has a completely different pathophysiology as far as I'm concerned. So we still have a lot. In other words, we're really including quite a few patients with different clinical phenotypes in this common syndrome that we call heart failure with preserved systolic function. However, what the guidelines want us to say is the diagnosis is clinical. Basically, we need signs and symptoms and preserved systolic function or relative present. We need to make sure the patient does not have right side heart failure isolated or other underlying structural heart disease. And in general, the echo and actually a BMP pretty much is considered to be, or pro-BMP, are useful to increase sensitivity and specificity of your clinical diagnosis. The patient is not really a great historical. And at least the Canadian NMA Association of Heart Disease and AHA and ACC agree on that term. So I talk about definition of epidemiology and diagnosis. Notice I did not talk about prognosis. The reason I'm not talking about prognosis is because if you read 10 different papers, 10 different studies, where you look in the Framingham data, or you look in the local population-based studies in Minnesota, or you look in more of a studies, double-blind randomized, that look at ARB's role, they're completely opposite results. So prognosis varies anywhere between feeling much worse than the regular heart failure with low ejection fraction to much better, or having the same prognosis as the other one, which what it tells me is that probably each of those studies will look at slightly different population. They have a certain population bias, and really we still cannot define well a certain subgroup of patients. The second thing that is important is in those studies, when they look at prognosis, as opposed to heart failure with low EF, where most of the mortality is derived from pure cardiac-related mortality, where there is sudden cardiac death and progression of heart failure. In patients who died in the clinical trial with heart failure with preserved systolic function, over 2/3 of them, they do not die of progressive heart failure. They actually die of kidney disease, infections, other things, which is telling me that we're really not altering here, and we're not. Those trials don't tell us much about what's happening with the real underlying structural heart disease in those patients. And it's probably because it's a heterogeneous group with a lot of other variables. What I would like to do is to give hopefully a cardiologist perspective on the echocardiographic assessment of heart failure with preserved systolic function, and try to translate for an internist what certain terms we have from echo diagnosis that will be useful for you in the day-to-day clinical practice. So first of all, what are the echocardiographic parameters which are useful to diagnosis, prognosis, and treatment of heart failure? And we have actually that kind of data. So echo in the clinical practice has been used to actually assess the degree of diastolic function, has been used to assess the cardiac filling pressures, and I would say that that's very important, and then to the prognosis. The degree of diastolic dysfunction is important because that's how we call it heart failure with preserved systolic function, so echo data will allow you to do that. Assessment of cardiac filling pressure is absolutely essential because the signs and symptoms of heart failure are pure related to how elevated are the cardiac filling pressures. If the cardiac filling pressures are normal, patient will be asymptomatic, therefore does not have heart failure with preserved systolic function. So having actually an objective, non-invasive estimate of that allows us to guide our clinical diagnosis and treatment, I think is very useful. So quick things that we obtain from the echocardiograph assessment of heart failure with preserved systolic function. We can look at the Doppler of the mitral valve inflow. We can look at Doppler of pulmonary vein inflow. In other words, tells us how blood flows through mitral valve, how blood flows into the heart through the pulmonary vein. We can look actually at the heart muscle velocities themselves. So if you have a myopathy, and those tissue velocity is going to tell us that there's a problem. We can look at indirect measurement of chronic elevated cardiac filling pressures, like left atrium volume and left ventricular mass index. So those parameters, I'll show you some data, have been shown to be incredibly valuable, at least as prognosis for these patients. So in a nutshell here, I don't want to bore you to details. So really, you don't need to memorize these squiggles. What you do need, what I would like to go over is actually what is really the substrate, the physiology substrate of this measurements that we have. Basically, this is the systole, this is an aortic pressure measurement, this is a left atrial pressure measurement, and then we plot them together. This is during the systole, you have a nice raise in the left ventricular pressure. You get, then the systole ends, you get the aortic valve closure. Immediately after aortic valve closure, you have an isovolumic relaxation, okay, where the left ventricular cavity is closed, and then pressure suddenly drops in the left ventricle. It's a very, very fast slope that purely relates with the degree of diastolic and systolic function. And then once the left ventricular pressure at the beginning of diastole gets lower than the left atrium pressure, then you create this pressure gradient. It's called a mean pressure gradient, mean transmitral pressure gradient, which actually is the driving force why we feel our heart in diastole from either the left atrium or the right atrium. And if that's the case, and you put what we call a Doppler, in other words, you put a transducer right at the tips of the mitral valve leaflets and try to record all the red blood cells that go through this. They will record the cumulative of all those red blood cells rushing in with certain velocities through the mitral valve. Then you record this E wave. Then you're going to have really 2/3 of filling occurs during this E wave on the mitral inflow. And then you have an atrial wave. This is the atrial kick at the end of diastole, which usually has about 20 to 30% contribution to the diastolic filling. On pulmonary vein flow, pulmonary vein flow is a little different. While in mitral, really, it's open only in diastole, pulmonary veins are open all the time. There is no valve between pulmonary vein and the left atrium, or on the right side, there will be hepatic veins and the right atrium. So what do we notice here? If during the left atrial, during the left ventricle systole, actually the left atrium itself, it's in relaxation, it's in diastole. So if the left atrium is relaxing, that means the pressure in the left atrium drops. That means the pressure gradient between the pulmonary veins and the left atrium is very high, so allows the heart, the left atrium, to fill during the left ventricular systole. So blood should flow towards the heart at all times. So you have a nice wave that's usually bigger than the diastolic wave. In diastole, basically the left pulmonary veins, left atrium, and left ventricle are all one common cavity. So really it's the pressure gradient between the pulmonary veins and the left ventricle that actually are the driving force to get all the blood sucked into the heart. So normally you have a diastolic wave that's slightly less than the systolic wave. And then there's a little atrial reversal wave that can help us to figure something there. But this is a normal pattern, all right? We can also look at tissue Doppler velocities. So what is tissue Doppler? Is instead of actually looking at what happens with the blood going through the mitral valve, that's blood velocities, we're looking into heart muscle velocity. We have the transducer is here. We put our probe here to try to sample what's the relative movement of the septum versus the lateral wall to the apex. And these velocities of the heart muscle in the longitudinal axis are going to be recorded, and we get a couple of systolic components and a couple of diastolic components. Really, what we have learned so far from the studies, what it matters is really mostly the diastolic component, what's called the E prime, which looks like a reverse image of the mitral inflow. And what we have learned is this, and this is something that we're going to give you. You don't need to memorize the numbers, but you need to know the significance of it. So if the E to E prime ratio, so that means if I look at mitral inflow, we get the E velocity. I look at tissue Doppler lateral or septal velocity, and I do an E to E prime ratio. If it's higher than 15, that means we have very abnormal relaxation, and this is associated in the studies with an elevated left atrium pressure and an elevated left ventricular EDP. What that means, that patient's volume overloaded and it has increased afterload, and basically that could explain most of those patients will have an elevated BNP level. Okay, all right. And this is one study showing that actually if you were to do invasive hemodynamics on anybody who comes in the hospital with acute decompensated heart failure, and you measure their E to E prime ratio and you plot that against the wedge, there's a very linear relationship between those two. I mean, the correlation coefficient is 0.87. This is almost unheard of in the biology. It's a tremendous strict linear correlation between these two. So again, the higher the ratio, the higher the LVEDP. That means the heart has to function on a higher elevated cardiac filling pressures. We can also just, we can actually estimate, and we can give you actually an estimated number. So we can tell you, as the elevated LVEDP is 12 or 15 or estimated at 30, or we can actually just dichotomize it. We can call it, if it's higher than E to E prime ratio higher than 15, then we know the mean left ventricular diastolic pressure, it's very high, it's higher than 15 or 20, and that's independent of the ejection fraction, okay? And if it's less than 8, then we know the cardiac filling pressures are normal, and it's between some, we actually don't know much about that. We need to use other variables. But bottom line is this was really important. So other things that we look at is the left atrium volume. You can have on the echo perfect normal echo reading. And if the left atrium volume index it's elevated, this is what we find on long term on patients, or over 100,000 patients from the clinical trials who have been followed up prospectively. If the left atrium volume index is over 26 mL per square meter, this correlates with an elevated pro-BNP, that means chronic elevated LVEDP. That's the translation for that. With the risk of atrial fibrillation, it will predict actually the stroke more than any other clinical parameter we have so far. It relates to hypertension, coronary disease-related outcome, and will predict on long-term heart failure hospitalization and mortality. Just a simple thing, having an increased left atrium. And you can start with, we used to report it as a size, now we report it as a volume because it's more sensitive. And if you were to look, it's like an exponential curve, the same way that our nephrologists have learned with the creatinine raise, that there is relative flat up to a certain level. And once you get it to a certain level over 40, then look at this is hazard ratio. It doesn't go up by 1 or 2 fold. It goes by every 5-fold up once you get it to this level. So in other words, anybody with big left atrium has very poor prognosis from cardiovascular standpoint. And that has nothing to do with ejection fraction or anything else. So that's a number that I think with time we're gonna learn to incorporate in our clinical prognostic strategy. So a normal diastole on the echo looks something like this. You have a nice E to E, bigger than A. You'll have some pulmonary vein flow. There's predominant systolic. And this is how it's going to look. Also on the tissue Doppler, you can have very tall velocities. So if I were to see how the movement of the septum on the lateral wall relative to the apex, you have big velocity, which means the heart muscle is really very compliant. It's moving very well. All you want to know is normal is that you have very tall velocities. So that's great. All right? Now, how about this patient? It's a patient who is 76 years old, has been in previous good health, so no prior conditions, comes to outpatient heart failure clinic for 4 weeks of progressive shortness of breath associated with lower extremity edema. He has a blood, in the office, we noticed he's got a blood pressure of 150/94, high rate of 80. The right-sided pressures don't seem to be elevated. He's got a little bit of peripheral edema, has normal kidney function, chest X-ray is normal, EKG shows some sinus urine with a little LVH. He's got a BNP level that's borderline elevated. Remember, this is elderly, and so often BNP levels are a little higher than the normal ones, but 250 nonetheless is still abnormal even for that age. And on echo, we see a mild to moderate concentric left ventricular hypertrophy with a preserved ejection fraction. And the right side seems to be fine, and I don't see any significant other underlying structural heart disease, at least on the echo. So how can now diastolic function assessment help us with the treatment of this patient? So this is how one of these echoes will look like. You get a little hyperechogenic myocardium, a little left ventricular hypertrophy, ejection fraction is normal, no major mitral regurgitation. If I were to do the echo and look now at diastolic dysfunction, then the first stage of diastolic dysfunction is called impaired relaxation. So what that means, if you were to look back here to the invasive hemodynamics, you see what happens with the left atrium, left ventricular pressure decay during the isovolemic relaxation is not going to be, the slope won't be bang vertical anymore. It will be much, much slower. So if the slope is lower, that means the rate at which the left ventricular pressure decays during the early diastole is going to be slower. That means the left atrium pressure will get to be higher than the left ventricular pressure at the beginning of diastole much later. Because of that, the mean gradient is the main driving force originally. The mean gradient between the left atrium and left ventricle, that's the main driving force to get the blood in the left ventricle. It gets small. okay? Because we have what it says, impaired relaxation. The heart relaxes slow, all right? And because of that, then our E velocity is going to go down. Then there will be more blood left over in the left atrium, which the preload will have increased. The atrial that will stretch the left atrium will increase the preload of the left atrium. And going to have a strong A wave that will try to compensate to finally get all the blood out of the left atrium before the new systole is going to start. So this is where we notice that the E to A ratio starts to become less than 1 as opposed to be more than 1. And indeed, we have a way of looking at the pulmonary vein, and we can figure that out too. Because the E wave gets smaller, D wave just follows the E wave. D wave will get much more than S wave. So this is called impaired relaxation pattern. What does that mean for a clinician? What it means is that these patients at rest probably may have normal cardiac filling pressure. The wedge could be normal, or it could be abnormal. And actually, so this stage can come with normal left ventricular LVEDP at rest, or it can come with elevated left ventricular LVEDP. And there's a way we can tell that from pulmonary vein, okay? If it comes with elevated LVEDP, BNP will be high. It will come in the hospital. Dave Watson will treat his blood pressure. We're going to give 80 IV of LACEs. Next day, patient can go home once the blood pressure is controlled. So it means you have an evidence that you have a little volume overload and you have a little bit of increase afterload, and that's probably what's triggering this heart to act stiff. And indeed, you see in this particular patient had the E to A ratio less than 1. The pulmonary vein flow showed that, the same pattern of abnormal relaxation pattern. And then we'll look at the E prime velocity, which will be this one. Instead of being more in the 10 to 15 range, the E prime starts to go down. So even if the ejection fraction is normal, this heart is myopathic. The heart is not relaxing well, and that's how we figure from tissue Doppler velocities. So in general, you don't need to memorize this. What you do need to understand is this is for us to tell you that we have impaired relaxation pattern. What it really matters is that the way I see diastolic dysfunction, at least at this stage, I have two conditions. I have a substrate. There is an underlying structural heart disease for this particular patient. It's probably long-standing hypertension was not recognized, could be age or not age-related. It caused left ventricular hypertrophy. That's my substrate. I got stiff heart and stiff arteries. However, you also have to recognize that it took 10 to 15 to 20 years to get there. Why is it that now patient presents with symptoms? And the reason why it presents now is because this is where the age criteria comes into function too. When we age, the first organ that ages in our body is actually the kidney. And I don't know if it's because of hemodynamic stress, seeing 20% of the cardiac output per minute, but kidney starts to age around 60 or mid-60s. And it has something to do also with endothelial dysfunction. If that happens, then kidney is going to start to retain sodium relative to what's our intake. So you start to have a mismatch between your intake of sodium and output of sodium. You're going to start to have tendency to retain sodium. You retain water, and if you get older, you depend less and less on being able to cook at home. You go and eat out. There's even more salt over there. And then I would say that many of these patients are set up to actually become hypervolemic, whether they like it or not. There'll be a simple explanation without a major deal. Of course, there's more than that. So, but what I would like for you to separate when you look at heart failure with preserved systolic function, for the sake of it, into two different conditions. One condition is try to figure what's the underlying structural heart disease. Also know that the underlying structural heart disease is years and years and years of evolution. And then that means you have to look for some certain trigger. What is the trigger for decompensation for this patient of this syndrome? For this particular patient, what I have is high blood pressure, obviously is not well controlled. And then the other one is hypovolemia. How do I know that? I got peripheral edema, I got shortness of breath, I got evidence on the echo of elevated wedge and an elevated BNP. So if I treat, and so the way it looks is this. I got a heart that this is if I plot the left ventricular end-diastolic volume, this is really the simple version of Frank Starling law. If this is the left ventricular end-diastolic volume, this is the left ventricular end-diastolic pressure, we know there is a clear relationship between the volume and the pressures. The higher the volume, the higher the pressure. But the compliance of the heart is very different depending when you are on this relationship. So if you have a normal LVEDP, then the compliance is much better. If you get if you have LVH and you have a stiff heart, once you get your LVDP in the higher range, over 20, that's when you start to manifest this diastolic dysfunction. So to me, this is my underlying substrate, which will be the diastolic dysfunction, LVH, but the trigger is the volume overload of hypertension. So what I need to do, and this is mobile, so what I need to do is get the patient from here to here, and then it could behave almost just the same like the other person that is next and doesn't have any kind of stiff heart. All right? And if I were to look another way, look at pulmonary capillary wedge pressure and left ventricular diastolic volume, because we really somebody with normal heart at rest has a certain wedge of 5, LVDP of 5. If you exercise, it will tend to go up, but it really never gets clinical significant that you get heart failure from this, okay? But the patient who has some kind of diastolic dysfunction, impaired relaxation, their wedge could be normal at rest, so they're 10, but they are higher than the other guys. But the moment you walk them around a little bit to exercise them, or you start to expand the intravascular volume, or they get atrial fibrillation with rapid ventricular rate, or they get other factors that may affect the diastole, then suddenly they start to be symptomatic. So my job, when I see the clinician, I think, okay, I got underlying structural heart disease, and I need to figure what's the trigger. And once I figure the trigger is volume, I normalize the volume status, then the patient needs to move back here to rest, or even lower than this. And so I can get him outside of functioning on this side of the slope of the pressure-volume relationship more towards here. The patient will do just fine. So that was stage 1 with diastolic dysfunction. It's dynamic. Most of the time, as I mentioned, patient will not have symptoms of rest, but they will have symptoms with exercise. So LVDP can raise with that. Heart cannot accommodate that. Now, if we go for the next stage, which is we call it pseudonormalization, or stage 2 diastolic dysfunction, or moderate diastolic dysfunction, then suddenly on what we have this time, we are going to have a structural heart disease, an underlying structural heart disease. We're going to have mild concentric left ventricular hypertrophy. We're going to have the heart starts to look on the mitral inflow more like pseudonormalized pattern. The reason why it starts to look like that is you still have actually the isovolemic relaxation phase that actually it's slow. You still have your impaired relaxation pattern on the LV. But the left atrium has stretched so much, the left atrium pressure becomes now chronically elevated. That is going to become higher, the pressure at the beginning of diastole in the left atrium than that left ventricular early diastolic pressure. So even the slope is still wrong. Now you have left atrium volume is expanding. The left atrium starts to function at LA pressure of 20, 25, and it's going to maintain actually the pressure gradient. So we establish the pressure gradient and the mitral inflow. So suddenly you have a lot of blood rushing into the heart at the beginning of diastole, which wasn't before. Sometimes this may confuse an inexperienced echocardiographer or cardiologist, but not those who know that we have other ways of actually looking at the heart. First of all, the pseudonormal is pseudonormal. If I have underlying structural heart disease, it can't be normal. You can't have normal LVH with pseudonormal on the pattern. So it's just a simple thing for fellows who are confused about all these different details. The second thing what it means is that we can look at pulmonary veins, and we're going to see that actually now the left atrial pressure is increased. That means the pressure gradient between pulmonary vein and the left atrium at the beginning in the systole is going to be reduced because the left atrial pressure is high. There is no valve between pulmonary vein and the left atrium. Although the left atrium is relaxing, it's already filled with blood, so it's going to reduce the pressure gradient across. The S-wave starts to go down. All right? So now for a clinician, what this means when I tell you back on the echo report, there's pseudo-normalized pattern on the diastolic dysfunction, what it means is that patient walks with a left atrial pressure of 15 to 25 millimeters mercury. They have elevated LVDP, and this is at rest. So these are patients who, even if they're not incredible, good historians know they have open heart failure. You need to treat that. How do you treat that? That's a different story. But bottom line is that it implies two things. Number one, there's an increased volume. So patient is hypervolemic, and you got to go back and talk more with the patient about signs and symptoms of heart failure. Two, they probably have increased afterload too. So actually diuresing the patient, normalizing their volume status and the afterload may help that. And of course, often we can figure that the pseudonormal pattern also with the E to API ratios. There are many ways how we can say that on echo, but this is really in a nutshell what pseudonormalized means. That means the heart is starting to function on higher resting elevated cardiac filling pressure, and that's at rest. So this is clear. Most of the patients come actually in the hospital with heart failure with preserved systolic function will have this pattern. So even if the EF is 65%, don't ignore that. Don't send the patient home without diuresing them, without you go and talk to, about the symptoms and everything else, all right? So what I was saying here, you have evidence of end-organ damage on the heart, even if the ejection fraction is preserved. And, for the fellows, if they want to go in details, you can see that indeed the E to E ratio gets back to pseudo-normal, gets more than 1. But we know the systolic wave in the pulmonary vein starts to get less than the diastolic wave. And even if the ejection fraction is normal, the tissue velocity starts to become very, very low. And it's telling us there's an underlying myopathy. This is not just hypertension and LVH, it's hypertensive heart disease. And sooner or later, the ejection fraction is going to go down too, but that correlates to the E to E prime ratio that's high. So last but not least, the most advanced stage is called restrictive physiology, or severe diastolic dysfunction. So what that means is now the pressures inside the heart get higher and higher. Initially, we only had elevated left ventricular end-diastolic pressure. Excuse me, I think I'll summarize that later on. But in the first stage, you only had elevated LV end-diastolic pressure. So in other words, the heart may start to be having elevated pressure only at the end of the diastole, a little high blood pressure, a little volume overload. On the second stage, you start to have also left atrial pressure goes up to compensate to be able to keep pushing the blood through the left ventricle or in the mitral valve. And the last stage, both the left atrial pressure and the LV-EDP and the left ventricular pressure gets higher earlier and earlier in diastole. An advanced heart failure equals a heart that's dying in early diastole. The heart cannot feel at all. And that's what it is. Your pressures inside the heart gets higher and higher earlier and earlier on diastole. So what that means is that no matter how high is my left atrial pressure, the left ventricular diastolic pressure, what we call mean left ventricular diastolic pressure, gets higher earlier and earlier in diastole and will overcome very quickly that huge left atrial pressure. So basically what it means, the filling through the ventricle gets shorter and shorter, and it occurs at much, much higher pressures. So that's why suddenly we're going to have a very tall E wave and very narrow. And it's sad because that means you have no way, if your diastole is short, that means you don't have blood going from the lung into the heart, basically. And these people will be incredible symptomatic. They'll be very short of breath. And we know that actually the more advanced is the restrictive physiology, the shorter the deceleration time. This simple number, which means basically we measure the time it takes from the peak to the decay of the E wave, correlates actually with the prognosis. It's probably the single most important negative prognostic factor we have from the echo currently. It's way more important than ejection fraction. It's way more important even than GFR and creatinine, which we know is very important for our patients. This short deceleration time. That's what we mean by restrictive physiology. And that's independent of the etiology. This has been studied in patients who have restricted cardiomyopathy. So remember, we call it restrictive physiology because that's what it is. The blood is restricted to go into early diastole, okay? But that does not tell you the underlying structural heart disease. You can have restricted cardiomyopathy with cardiac amyloid. You can have just severe LVH with hypertension. You can have end-stage renal disease on dialysis. Heart is just very very stretched. And so on any deceleration time that's less than 150 milliseconds, very, very poor negative prognostic factor independent of the etiology. You can have three-vessel disease going for cabbage. All right? So I'll give you some examples. This is a patient who is 22 years old. He's got dyspnea and exertion. You see it's a hyperechogenic, very thick heart, has normal blood pressure. This is a young man who has hypertrophic cardiomyopathy. Okay? When we look at, if you were to just look at the ejection fraction, 65%, it should live for a long time. Well, but actually when we look at diastolic parameters, this is very tall E to E wave. It's very low systolic wave, which means the left atrial pressure is very elevated, and tissue velocities are very low. So even if I have a lot of muscle, it's not working, really. It's myopathic. And actually, we can tell we have now answers to all these questions according to echo. We can tell what's the left atrial pressure, what's the left ventricular diastolic pressure, what's the LV-EDP, overall what's the diagnosis, and even what's the prognosis. And I told you that's because, and these are the numbers, and these are the answers. The left atrial pressure is over 50 millimeters mercury according to this. The mean left ventricular diastolic pressure is over 20. If you were to do SWAN, you would see these numbers. If your LVEDP is over 24, and this is called stage 3 diastolic dysfunction with restricted physiology, and we know this patient has life expectancy under a year according to short deceleration time. So even if he's 22, he's got normal EF and LVH, right? Send this patient to heart transplant. He's not gonna live long. They have a high risk of sudden cardiac death, very different when you just look at the ejection fraction. So if I were to summarize all this diastology, I don't want you to memorize any of this. This is irrelevant. What you really need to understand is that when you start from normal, if these are the cardiac filling pressures, when you go through various stages of diastolic dysfunction, one way or another, we also tell you what's happening with the cardiac filling pressures. And the heart functions initially with normal, resting, cardiac filling pressure. Then they start to, and initially they have problems only with the exercise. Eventually, they start to have high resting left atrial pressure and LVEDP. And on more advanced restrictive physiology, both left ventricular mean diastolic pressure and left atrial pressure gets to be over 25. That's the status quo. Is what I call class 5 New York Heart Association. That means we can't get them out of class 4. So it's class 4 that goes back between 4 and 3 and 2, and there's class 4 that stays in class 4. Those will be patients who are waiting for heart transplant, or be patients who are end-stage renal disease on dialysis. You try to pull off fluid from them, they pass out. You can't, they have stiff, small heart or weak heart, and you can't really get them out of that high cardiac filling pressures. So, so I show you how we can actually, with echo, we can assess the degree of diastolic dysfunction, we can determine the prognosis, and I'll show you some other way. We can assess the left-sided pressures, but we can also assess the right-sided heart pressures. And that's very important, particularly for our patient, our pulmonary colleagues. It's also important for our nephrology colleagues, because if you have a right atrial pressure of a 20, the renal veins cannot drain blood into the right atrium. You have a reduced kidney pressure gradient that goes across and the kidney is not going to function well. And if you have a bad right-side heart failure, you have severe pulmonary hypertension. We know that's probably one of the most important independent prognostic factors that relates to the lung disease. So we can estimate a systolic PA pressure. Pay attention to that on the echo. We can estimate even the wedge from the pulmonary regurgitation jet. If we have a good one, we can tell you. We usually look at that, plus we add the right atrial pressure, and it's very reliable. Maybe more frequent, what you see all the time on the report, is actually that we can estimate right atrial pressure. We use certain variables, but one of the things that you really need to pay attention is when we say systolic flow reversal of hepatic veins or lack of respiratory variation on the inferior vena cava. What it means, the right atrial pressure is so high that the IVC doesn't move with the respiration, and you're gonna have a right atrial pressure is over 20. So here, this is what it means, a systolic flow reversing hepatic veins. Our pressure transducer here at the liver level, you see this is the right atrium subcostal view. The inferior vena cava is very dilated, and you see red flow going towards the liver, which means it's away from the heart. Now, if you have veins, right atrial pressure is 0. Really, you want your blood to go towards the heart, not going away from the heart. So the blood goes away from the heart, the liver is not going to function, the kidneys are not going to function, the whole mesenteric system is not going to function. These patients have early satiety. They don't absorb their medicines, and they don't they don't get their nutrients. They actually start to reabsorb only sodium and water from their stomach, which is still working, but they're actually starting to replace their dry mass with by burning their own proteins with water. So if you send a patient home like this, who has heart failure, preserved systolic function, ejection fraction is normal, and I told you he's got systolic flow reversal on the hepatic veins, whatever medicines we put them on discharge list, nothing gets into the body. There's no way you're going to keep this patient outside the hospital. There's no way you're going to do anything from whatever medicine you give that you think is supposed to treat any kind of underlying disease, whether it's diabetes or anything else. So this is very, very important variable. Know that those organs depend on these pressures in order to do their job. And then we can also estimate the systolic PA pressure, as I mentioned. And this is a simple example. This is a slide that I borrowed from Dr. Navarrete when he gave his ground rounds a month ago, where he showed that actually if the renal function purely relates to the CVP in these patients who have heart failure. Okay? The higher the CVP, the worse is the risk of renal dysfunction. All right? So I think in conclusion, I wanted to point out that with echo, we provide you a lot of very rich information to actually manage the patients, but we got to pay attention to it. Don't just look at ejection fraction. There's way more, lots more going on there, and try to correlate with other things that you have there. If we tell you that the cardiac filling pressures are elevated on the right side, go back and talk to the patient. You may elicit more, cell early satiety. Maybe they eat small portions they just got used to. That means you got to diurese them more before you send them home so they can actually stay home. You can look at the, if I tell you that a pseudo-normalizer on the diastolic function or restrictive physiology, even if the BNP level is 1,000, it looks like the patient's asymptomatic. That's bad news. That patient will be back in the hospital with heart failure, even if he's not going to yell at you and tell you that. So be very careful. And remember the chronic heart failure, the chronicity of the heart failure, it's a very different beast as presentation than acute heart failure. Acute heart failure is very noisy. You can't tolerate acute rise in your cardiac filling pressure without being very symptomatic. Easy to hear. You're going to hear rails. The patient's going to be very short of breath. If you have chronic heart failure, you allow the compensatory mechanisms, the patient will adapt, and often the symptoms will get less and less. You're not going to hear the rails. The incidence of rails in chronic heart failure is under 10% because the fluid gets out of alveoli in the interstitium, and there's no way you can hear it. There's no way you can see it either on chest X-ray. The only one who will tell you that I got heart failure will be actually listen to the patient. They get this pneumonia exertion with less and less effort, or they get early satiety on the right side. So that's very important. And we have variables like distillation time that tell you the prognosis of the patient, and you can use that for potential. So let's talk about treatment of heart failure preserved systolic function. Remember that I was telling you that unfortunately the clinical trial haven't really showed much. So if I review the ACE inhibitor trials, really probably the best clinical trial we have for that is the candesartan CHARM trial. It's called CHARM with preserved EF heart failure trial. Really, they randomized patients with an ejection fraction of over 40% and clinical history of heart failure to either candesartan up to 32 milligrams once a day or placebo. The trial was followed for almost 3 years, so this is relative long-term follow-up. And their primary endpoint was death from cardiovascular causes or hospital admission because of heart failure. That was not statistically significant. What was statistically significant was actually just isolated the hospital admission per se. The p-value was 0.01. Unfortunately, a subsequent trial with a similar, it's called irbesartan, which was published last year. I don't have it here. It showed absolutely zero. And telmisartan showed no difference whatsoever in the outcomes up to 5 years follow-up. Then if you look at other like beta blockers, probably the best beta blocker clinical trial is called Seniors trial. These were elderly who were randomized to placebo versus nebivolol. Nebivolol is a carvedilol-like agent that also has nitric oxide type release ability. It's a vasodilator that is very popular in Europe. It's been recently approved here for high blood pressure, not for heart failure. And what's interesting, this included patients with both systolic and diastolic heart failure. And if you look only so overall, the clinical trial was positive, but due to the systolic component part of it. When they look at diastolic part, it didn't really make any difference. And then the others are all small trials that really, digoxin didn't show anything. Now, we do have some potential benefits with ARB and diastolic dysfunction per se. So that has nothing to do with signs and symptoms of heart failure. This is impaired relaxation, in other words, underlying structural heart disease. I notice some impaired relaxation. I want to see if I treat the patient, they have high blood pressure, and the hypothesis of this Valley trial was whether treating the blood pressure, normalize the blood pressure control, either with an ARB versus like valsartan versus normalized blood pressure with any kind of antihypertensive medicine, made any difference or diastolic dysfunction parameters themselves. And at the end, what seemed to be interesting is that the more the patient, the more you had, the higher you had the drop in your blood pressure at the end, a systolic blood pressure at the end of the study, the more likely you were to improve your diastolic parameters. But it made no difference where you achieve that with valsartan, an angiotensin receptor blocker, or with amlodipine, thiazide, the usual ways. What it means is, once again, when it comes to hypertension and an endpoint, particularly structural heart disease, the the more as long as you control the blood pressure, it doesn't matter how you're going to achieve that, all right? At least in the absence of other comorbid disorders like diabetes. This is just pure isolated hypertension, okay? So that's important. In other words, our diastolic parameters from the echo do follow structural heart disease, and they correspond to the prognosis, whether you go that way or that way. And but unfortunately, the drug themselves has not appeared to alter the long-term outcome of the patient, but it may improve the diastolic parameters. So the current guidelines tell us that in patients who have actually heart failure with preserved systolic function, the physician should control systolic and diastolic hypertension in patients with heart failure normal EF according to published guidelines. The physician should control ventricular rate, so look at triggers for decompensation. So somebody who's got AFib with rapid ventricular rate, it's a problem. Somebody who's got active ischemia, it's a problem. Or somebody's got clear congestion, volume of low, it's a problem, and you need to treat that. Basically, I'm getting close to finish this. In conclusion, the diastolic heart failure is increasingly recognized as a common clinical syndrome. However, diagnostic criteria are still subject to debate. I think that is more of a syndrome than a true entity here, and probably are incorporated 2 or 3 causes of heart failure that we don't have a clear, cause for, and and probably that's the reason why the clinical trials have failed, because you have some criteria that try to incorporate all different causes of heart failure with preserved systolic function. And I really think that the 4 years old with hypertension and LVH, if that goes into diastolic dysfunction, heart failure, it will be very different prognosis than the one who is 80 years old with a little LVH, okay? The second thing, the large, high-quality randomized trials of angiotensin-converting enzyme inhibitors, beta blockers, angiotensin receptor blockers, and digoxis do not show any improvement in survival rate. The angiotensin receptor blockers appear to reduce at least the rate of hospitalization, due to heart failure, and is associated with the increased risk, but it's associated with increased risk of hypotension, renal failure, and hyperkalemia. So if you do that, of course, we know we got to follow these patients. Don't overtreat, in other words. In the absence of evidence-based intervention for diastolic heart failure, clinicians should focus on treating the comorbidities or whatever you find it's an underlying condition that's associated with your heart failure, such as hypertension, atrial fibrillation, and coronary disease. So the way I separate when I see a patient with heart failure, first of all, I make every effort to really make sure that I don't find other cause of heart failure, explain the patient clinical status. In other words, if I have a 4 years old who is 400 pounds, who's got sleep apnea and right-side heart failure, that's not heart failure with preserved systolic function or diastolic heart failure. We may have a little LVH. That has nothing to do. That doesn't cause you 40 pounds of fluid overload. Probably the patient has untreated sleep apnea, and you need to work on that. You need to, normalize the volume status, work on, on sodium dietary instructions, and work on diagnosing and treating the underlying sleep apnea. Then after I try to figure what's the underlying structural heart disease, then I immediately focus on treating the trigger that made the patient come in the hospital. Yes, I have 20 years of hypertension with mild LVH, but that's been going on for a long time. This patient is not, it's only in the hospital now. What is it? Most of the time it's actually a congestion that has been triggered by one or another, either more wrong dietary habits, or kidney not doing well, or got a urinary infection, something is going on there, and you gotta try to remove the fluid and normalize the cardiac filling pressure so the patient functions from the high LVEDP to normal ones. Second, maintain the atrial contraction and prevent atrial tachycardia. Just a caveat here is what I call appropriate. There is what I call appropriate tachycardia, and there is inappropriate tachycardia. If you have a septic shock, you're sure you can have LVH, you have a banging heart, you can have diastolic dysfunction, but it's normal with septic shock to have sinus tachy at a heart rate of 130, particularly the patient is resistant to pressors. Now, if you have atrial fibrillation with a heart rate over 140, that's inappropriate tachycardia. So make sure that you're, in general, if the patient actually has sinus tachy, until proven otherwise, the rule of thumb is that just tells you how bad is, and there's some bad underlying condition going on. It's just a mark of severity. It shouldn't be a goal of a treatment itself, all right? So be careful with that. Don't overtreat if you try to block sinus tachycardia in somebody with septic shock, you'll be surprised once you get a heart rate of 80, the patient is gone. So you can't get them back. So don't, make sure they understand the difference. The second, treat the myocardial ischemia, control the blood pressure, and where really when it comes to goal number 2, which is treating the underlying substrate, really this is what we don't have a lot of evidence-based medicine for. I actually think the future probably is going to select those groups very specifically. In other words, I hope one day we're going to do a clinical trial where we're going to look only elderly-related, isolated, diastolic dysfunction, and hopefully we'll come with drug for that. Then we can look somebody who's got 20 years old and hypertrophic cardiomyopathy. Hopefully we're going to come up with drug. There are many ways how we can interfere. But so far, agents that alter the underlying structural heart disease, like it happened in low ejection fraction, we don't have much. The only one that we have a little bit of evidence is to promote the regression of hypertrophy and prevent myocardial fibrosis are the ACE inhibitors, but it depends on the stage of the disease when you start. More recently, and we need to pay attention to, fibrosis is part of many underlying structural heart disease that causes are related with, with heart failure with preserved systolic function, whether it's in renal disease, whether it's in cardiac amyloid, whether it's in any other condition or long-standing hypertension. So actually, NIH has designed and started about 5 years ago a long-term heart failure with preserved systolic trial with spironolactone, trying to target actually the fibrosis with spironolactone. And it's called TopCat trial. Probably is going to be the endpoint really is going to be reached within 7 years. So this is a long-term trial. So we're going to see, hopefully we're going to have news within a couple of years of that. But until then, really, we don't have anything else to offer you. Thank you, and I'll be happy to take any questions. Go ahead.
Did with Dr. Sung a couple years ago. How easy is it to get tissue Doppler studies? Because I was given the impression it's fairly tedious as far as the time it takes to interpret all the data.
Depends what you look at. If you just look to simple sample the septal lateral velocity, we have our sonographers here. They can tell it takes them, what, a minute or 2? I mean, it's very epical for. Now, if you want to measure the systolic or diastolic desynchrony, I didn't talk about that, so you can get very fancy. Then that's a different story indeed, because that's when we have a lot of issues with, that could be a study that can take another 30 minutes, but that's not what we use in common clinical practice. So the simple one is incredible. You actually, each and every report we have right now, we measure those by default, and you actually have the number there. And our cardiologist really is supposed to actually translate that for you into giving you, is this stage 1 or stage 2 or stage 3 diastolic dysfunction respiratory physiology. But know that all those, when you have the diagnosis, all the other factors are included in that report. So, go ahead, Dr. Messer.
These are the most difficult to treat as far as they're preserving kidney function, especially if they already have CKD underlying.
That's correct.
And so, what's the a trick to treat those? Because once you give higher dose of diuretics, their renal function gets worse. Is that due to itself diuretic-induced vasoconstriction? Because you are not achieving much diuresis, but renal function is still going worse.
So, so the question is, we know anybody with any kind of underlying kidney disease, chronic use of diuretics is associated with progressive renal dysfunction. There's absolutely no doubt about that. In the same time, what I think we disagree is that diuretics are the evil. I mean, yes, you don't want to use a diuretic, but the patient is suffering from volume overload, and you got to get them out of the hospital. So one way or another, we have to use them whether we like it or not. I think the key is to, and this is where we have the disagreement, is what's the best strategy to use. Shall we use a high-dose bolus, Lasix, and then give a break for a day or 2? Or should we use a low dose every 6 hours? Shall we use a once a day, a twice a day combination? Shall we add any kind of other agent? When do we add it? So that's not too clear. However, what is, I think, we're starting to have a little bit of let's see if I have that here, from a little bit of light, probably the first evidence-based medicine clinical trial that we had. And I'm sorry, looks like he's removed my slides from before. Let's see, from 2 weeks ago. Nope, I don't have it. Anyway, I will refer you to, we have finally, so in March 3rd, about a week ago, New England Journal just published the first double-blind randomized trial or various strategy in diuretics use. It's called the DOSE trial. What they have done is that about 350 patients who came with acutely decompensated heart failure, was organized by NIH, whatever the best experts, whether they were kidney or heart failure guys, they got together, including Braunwald, came up with this protocol. They randomized them to 4 different arms. The first hypothesis was to test whether high dose versus low dose makes a difference. So what the low dose was considered, you give IV whatever PO dose patient was at home. So patient was on 80 PO, got converted to 80 IV. That would be the low dose protocol. The second thing you could do that is the high dose protocol will be 2.5 the baseline converted to IV. So there was 80 PO of Lasix. Furosemide, you converted 200 of IV furosemide, which was divided into, you could give it now either low dose or high dose, either as a bolus, or you could give it as a constant infusion, Lasix drip. Because obviously there's a lot of perception from small studies. We all know that theoretically the continuous IV furosemide infusion will be less renal toxic, and theoretically you can remove more fluid. So the funny part is it took about, the study was presented at HCC about a year ago. It took almost a year to get it published because obviously the results, the reviewer did not like them. Obviously there's a lot of disagreement about the results. Nonetheless, this is the data. So the data is this, that at the end of the day, the high dose bolus furosemide, so 200 IV was actually the most effective to remove the fluid, to decongest, to improve the patient's symptoms, okay? However, that was also associated, and they got about 5.5 liters overall for the 72 hours period. Unfortunately, of course, the price we pay for that is that there is a slightly higher statistical significant increase, reversible increase in creatinine by 0.3 milligrams per deciliter, which is a very sensitive measure of looking at renal function. At the end, though, the beauty of this study, 2 months later, they got actually mortality endpoint, rehospitalization rate, now it's bounce back for heart failure, and all the surrogate endpoints. In other words, if you decongest the patient, you got them feel better, and you got a little worse renal function, temporary. Obvious patient did not go home with the same dose of Lasix. Did that translate to no adverse outcome at 2 months, long term? And the answer is no. So in other words, the bolus itself, high dose bolus was the best to relieve the congested and all congestion. And although there was a temporary increase in creatinine, that did not translate in a irreversible increase in creatinine or worse outcome at 2 months. Believe it or not, the Lasix drip, the high dose Lasix drip, or the low dose Lasix drip, are actually less potent to remove fluid than actually one bolus, high bolus does. This is a little bit of contrast to what we thought, because you think it looks like the kidney. What I think happens is, if you keep using constant infusion, all the data we have in terms of the overall sodium milliequivalence removal are for 6 or 12 hours. What I think happens, while it's a little more gentle, temporary, on long term is the faster way to actually cause probably diarrhea resistance too, because you have constant exposure. And we don't look at 72 hours to see what happens with that. The second thing is that, believe it or not, is actually the worst outcomes had the low dose Lasix. So actually 40 IV of Lasix, were low dose, whether you give it with infusion or not infusion, had actually high risk of VT, high risk of actually renal dysfunction, if you compare the low dose versus high dose, all right? So of course, a separate group. So what this seemed to basically says is, now, if the patient needs to be decongested, it really, the best way to decongest the patient is to use high dose bolus. It doesn't matter whether you use the drip or the other, it makes no difference. Know that you're going to have a higher risk of temporary increase in creatinine. I think the key is to follow up the patient and not continue to do it once you see the creatinine is going up. And know that that doesn't necessarily translate in a worse outcome long term. The second thing, the low dose bolus, 40 IV Q12 for Lasix versus drip, it really didn't do any better than actually high dose bolus. These are 300 patients, but nonetheless, the only double-blind randomized trial that actually addressed this specific question that you just asked me. So we'll see what's going to be, but that's the best we have. So
We better wrap it up for now. So thank you so
all right,
much.
you're welcome.